One Health Paradigm Agenda for Lagos State, looking at all the things that contribute to disease in Lagos State, after which we developed a joint movement with environmentalists and all other parastatals to limit the spread of disease in Lagos. Dr. Jide Idris battled a lot of problems in the Lagos health sector, and in fact, within the entire nation. Prominent among his achievements are the institution of a functional health insurance management scheme, as well as the containment of the Ebola outbreak within Lagos. This containment, it's safe to say, saved the entire nation from one of the deadliest epidemics that would have hit sub-Saharan Africa. This is due to the fact that in Lagos, the fastest growing city in Africa with 77 additional people per hour, the first strain of Ebola could have left the nation breathing. That is Dr. Jide Idris for you. Yeah, the next person on the panel is our own prof. Professor Akiabayomi. It doesn't need any more introduction. We have done that yesterday. And if you want me to, I can still read that out. Then we have Dr. Nahid Bandelia, too, on the panel. And let's give her a big round of applause. Or are we managing our hands? I'm sure we're not. You're welcome. I should do another profile for Dr. Nahid. Yeah. Dr. Nahid Bandelia is an infectious disease physician and the medical director of Special Pathogens Unit at Boston University School of Medicine. I think they know. Okay, no problems. I think they know. Then we have another doctor on the panel. Dr. Ismail Abdul Salam. Yeah, I think I don't have the profile of Dr. Abdul Salam, but I think Dr. Dotun, can I have it? I should go on. Okay. Okay. And then we have the last but not the least on the panel, we have Jennifer Marwa. And Jennifer Marwa heads the genetic program Human Heredity and Health in Africa, H3 Africa, an African human clinical trials portfolio of the African Academy of Science, the AAS. Prior to joining the AAS, Mabuka spent 16 years doing HIV clinical research. Our research broadly focused on understanding host innate and immune factors that modulate HIV-1 transmission and pathogenesis. She investigated host immune responses in mother-to-child transmission of HIV-1 with a focus on breast milk transmission and exploit antibody evolution in natural HIV infection with the goal of informing antibody-based vaccine design. Mabuka holds a PhD from the University of Washington Department of Global Health and spent 3 years as a postdoctoral fellow with the Reagan Institute of MGH, MIT, and Harvard and KwaZulu-Natal Research Institute for TB and HIV, now Africa Health Research Institute. She is currently a clinical associate professor at the University of Washington in Seattle and 2018 Aspen New Voices Fellow. Is she around? Doctor? Oh, why don't you come up? You have to come up. What? There's a chair there. Please, you have to. Please step up. Please, a round of applause for her. Oh, you're trying to have me. Okay. Okay, thank you so much. I really appreciate that. And then for Dr. Abdul Salam, is the state epidemiologist for Lagos State. So I think we have a complete panel this afternoon, and we are going to be talking to the issue of preparedness. How prepared are we in Africa? So, because we have a lot of you have different experiences from different places in Africa and outside Africa. And I think I'm going to pose the first question to Dr. Badelia. Yes. I think you've been involved in what is happening in DRC. And what is the real situation on ground now in the DRC? What is your experience there? And do you really think that as at the time we had the Ebola outbreak started in DRC, can you actually really say, maybe in your opinion or based on experience, whether they were really prepared to handle an outbreak of such a magnitude?
Again, for the misconfusion. So I currently work at the border of DRC on the Uganda side. I've previously worked in Sierra Leone, but I'm not currently working within DRC. However, I mean, we see everything from across the border. That's part of the story, right? I mean, I think whatever affects one country in a region here is something that translates to the rest of the region and the world. Professor Abayomi asked me to talk about why we think this outbreak is ongoing in DRC and why it's become so big. And I think in that are the lessons in terms of what the necessities of preparedness are. And I think why is the right question, because how is spreading, we already know, right? I'm going to share a couple of numbers that are from the August 2, August 3 reports that are coming out of WHO and MSF. 36% of the deaths that are happening in that outbreak are community deaths. That's almost 40%. In some places, 50%. So how is that happening? That means people are dying in their homes and in their communities rather than coming to care. So we know that it's spreading because the sicker you are with this disease, the longer you're in the community, the more likely you're to transmit this disease. And so part of the reason this outbreak is ongoing is because there is a disconnect, there is a distrust to coming to care. And the other number that sort of reflects that distrust and lack of access is most people aren't coming to care. The average number of days that have passed before someone comes to care in DRC ETUs or Ebola treatment units is 6 days. That's very long and well into the disease. And at that point, we're not even sure how well the medical countermeasures will work on them, even though we have these new tools. So that delay in seeking care and actually not seeking the care at all are two big things. And the other number, I think that's quite striking, is 50% of the new cases are not from any known contacts. That means we've completely missed where they're getting sick from. That we're not in places where these chains of transmission are happening, right? So the surveillance bit, we're not everywhere where the surveillance needs to be. And the last number that I think speaks to preparedness everywhere, I just heard last week, which was 11% of the patients, the cases between August of 2018 and August of 2019 can be traced back to healthcare facilities. So I don't mean ETUs, regular healthcare facilities. So basic infection control and prevention is the gaps, the holes where they're there in any of the communities that we work in. That's what this virus takes advantage of. It's a blood-borne pathogen before it is anything else, and it transmits pretty easily in nosocomial settings and healthcare facility settings. So I think for any region to be prepared, whether it is Sierra Leone or DRC or Uganda or Nigeria, the biggest thing is we need to do our everyday work well, everyday infection control well, because that's the only way to ensure, and this is the same story in Boston, by the way. When we have cases when someone comes in from the emergency room, people are not wearing gloves when they should be wearing gloves. People are not taking care of the patients the way they should be taking care of patients. And so that continuous push on infection control is one of the major things that we can do. The other is having centers of excellence, which Nigeria already does, to take care of pathogens with Lassa fever, with some of the experiences that are here. But I'll stop there. But I think those numbers from DRC really speak a lot of truth about it's not just the preparedness, but it's actually getting the trust of the communities that we work in.
Thank you so much. So we've heard from Hannah, it's not just about the preparedness, but there are some other factors that come into it. Yeah, I think we should move to Dr. Abayomi now. Yeah, Dr. Abayomi, based on your experience across West Africa in around 2014 and 2016 when we had the outbreak, what do you think could be really what we can say, these are the indicators of preparedness? You understand that if you really want to assess a system and analyze a system and really come out and say, yes, this system is really prepared to handle any outbreak of diseases, what would be the pointers?
Okay. So I think what we discovered from the Ebola outbreak is that we'd really never been tested like this before, with a pathogen of high consequence that spreads very quickly and is uniformly lethal without intervention. And what became apparent was, we just didn't have a roadmap or a framework. And I would start with the fundamental aspects of a framework, which are governance. When you have an outbreak, you're dealing with a dangerous pathogen, a pathogen that can be classified by international standards as a category A, which means it could be used for biological warfare or it could be used for bioterrorism. There are international treaties that adjudicate to how you manage that scenario in country and how you relate with your neighbors when such an event is going on. Now, our legislative structures are not refined to that extent where we've taken these treaties and we've domesticated them and implemented them and cascaded them down to operational level. So I think the first thing we recognized was that there were no laws that govern how you manage this kind of event. And those laws are both for domestic and international relations during such an outbreak, because obviously it's a national, it's a regional, and it's an international event. And so when you have something of this nature, then you often, without usually have international responders. So how do international responders operate with a national coordinating mechanism to implement support? Now, that's the international governance. Then at the local level, you have medical governance. So you're dealing with patients, you're dealing with biological samples, you're dealing with data, you're dealing with the sovereignty of a nation, and you're dealing with the human rights of the patients. So all the ethical governance attributes need to kick in. Now, when there is a situation where you have a chaotic environment around an outbreak scenario of this kind, if you don't have these medical governance structures in place, then it just becomes a very chaotic environment where everybody is doing whatever they feel like doing. Nobody knows the rules, nobody knows, the emphasis is just on bringing this outbreak under control by any means. So those are the two levels of governance. Then you have infrastructure and you have human capacity. What we certainly did not have was the physical infrastructure, number one, to make the diagnosis and to store the samples. And secondly, we didn't have the physical infrastructure to manage the patients. Going along with that, we didn't have the human resources that knew how to manage these kinds of cases. So, you've got medical personnel on ground. Many of them were getting infected because there was no training, there was no equipment, the environment in which they were working in was suboptimal, so they were getting infected. Many of them, obviously, and it's not surprising, You know, if you've not trained your medical personnel to manage these kinds of cases, why would you want them to risk their lives? So it's not fair on the medical personnel to respond in a situation where they haven't had adequate training. So those were the issues that we encountered, which obviously created even more of a compounding situation where our healthcare professionals were getting sick and those on ground were reluctant to respond, and we didn't have infrastructure. So one of the things we've been doing since then is trying to address these foundational gaps, you know, so that we have good governance at legislative level, we have good governance at medical, ethical level, we've got infrastructure, and we've got staff that are trained to handle samples and staff that are trained to handle patients. And those are the foundational principles of responding and preparedness.
Thank you very much, Dr. Bayomi. So, in your estimation, preparedness will mean having medical governance in place, having infrastructure, human capacity, and physical infrastructure. Thank you very much. I think the next question will be for Dr. Jide Idris. And as the immediate past commissioner of health in Lagos State, and you were really in the eye of the storm during the Ebola outbreak in Lagos. And I know it takes a lot of political will to address an outbreak of such a magnitude. And how were you able to rally the political will that you were able to really battle the outbreak and really deal with it, understanding that Lagos is a very political place and a cosmopolitan place? I don't know. And as the health commissioner, I know it takes a lot. So we want to really share your experience, because whether we like it or not, there is also a political aspect of addressing these issues.
That's a very easy question for me. Especially when I'm in the midst of professors. I'm not a professor. But you see, let me say that as a state, Lagos State, the smallest state in the country, but the largest population. And I think, again, I was lucky in the sense that I want to be less political. The first two governors of Lagos State, I must say, were people who took health as a priority. And they gave us total support. Because at that period, again, they increased funding to the health sector. And again, they were a bit of more proactive, because then they looked at Lagos State earlier on, and we sat down to look at what were we as a state vulnerable to. At that time, we're not even thinking of Ebola or whatever it is. We just were thinking of, suppose we have some disasters as a mega city, what we will do. So earlier on in the various terms, we're trying to develop some institutions. And I think it's those institutions, they might have been on the very low stages that we actually fell back onto. And so we more or less had something on the ground. But when Ebola struck and we were getting information from Presley, we had to tap on those. So occasionally we had to amend the functions of some of those things. I'll give you an example. Earlier when the first governor came into power, there was a whole lot of problems in Lagos State, because every day we were picking up dead bodies from the various roads, a minimum of 10 a day. Because of that, we had to create a unit just to go around picking up those dead bodies. We call them SEMU. Because when Ebola struck, is this same unit we had to hurriedly train to start doing decontamination. If you went to somebody's house or a suspect, you brought out a suspect, this unit went into decontaminate. Around the same time, we set up this ambulance service. It still needs to be developed. I remember one occasion we called this ambulance driver. I said, look, you're going to work with this. All of them were looking at me. I said, look, I'm not going to endanger your lives. But the first time they went out, they got the confidence and they helped in actually going to pick up these suspects or whatever it is from different houses. So there were things we were developing right from that we had to tap upon. And so when Ebola struck, let me say, okay, the other governor who took over, who was then the governor during Ebola time, I remember we were arguing for the budget, different ministries. And people will shut me down. You don't need this amount of money, you don't need this amount of money. I asked him, Governor, can you give me an extra amount of money to my budget? He said, if you continue again, I will slash your budget. I said, sorry, sir. But see, when Ebola struck, they asked me how much I needed. And I started laughing. They brought cash. Because at that time, you were never, look, you wanted to get it, you had to get it. Irrespective. So, and I remember he said that with the, I think, American ambassador there, because they gave some money to the federal government, and he was asking, they asked, look, has the federal given you the money? He said, look, I have the problem. I'm not going to wait for the federal government. I will spend whatever it is I need to spend. So that was showing the will to contain something, but that was there. So they had the financial muscle. They gave us the financial backing. But more importantly, again, when we were going on, we realized that you could not do anything positive without the people. You must carry along your people. And that's why it got to that massive public enlightenment, which also they funded. So you see, over the period again, the will of government was there because they placed priority on the health sector. I wish every government could do this, because then you don't know when this was going to happen. So as a state too, when we had this DRC issue, we had started planning, started discussing, suppose it came into Lagos. And luckily, about Dr. Abdul Salam, get out your people, get everybody out. And they had that patient who came from Congo to Nigeria. They were easily ready to, they were able to isolate the patient. But luckily, she wasn't positive. So I think you must have the support of your governor or your what do you call them? Yeah, no, political will. Because without that, it's also related to governance issue that he mentioned. Without governance, without police and everything like that, we can't do anything. Because that's what charts the way, the pathway for us.
Thank you very much, sir. That's, yeah, don't worry. You should be the next. Yeah. And yeah, for you, I think Dr. Abayomi said that containing Ebola in the area of local governance and international governance. And in your own estimation, how do these two governance structure comes together to ensure that we have a good response and ensure that we are able to contain it? I'll give you an example. In those times, when I want to travel, when I get to the airport, they just put something on my head and start to search and do. But after some time, they stopped it. But till tomorrow, anytime, even as at last month when I got to Korea, they were still putting it on my head and they were still giving me certificates before I went into Korea. And they put this big alert there. People coming from certain places that they needed to really watch out for them before coming into Korea. So how do we handle these kinds of responses? How do we make it a part of our system? How do we make it systemic?
Thank you very much. I think I want to borrow a lot from what my panelists have said. First, I think we appreciate that pathogens don't know boundaries, so we need to be ready at any time. But I also want to borrow what the Honorable here has said, that we need to define our vulnerabilities. And once we know what our vulnerabilities are, then we can put the structures in place that we need to be able to respond in case of emergencies. So I need to share with you that when I came in through the Abuja airport yesterday, they were taking the temperatures on the screen. But I also want to highlight an incident that happened in Nairobi on Friday last week when I was in Kampala and we were going back to Nairobi. And when we got back to Nairobi, one of my colleagues said that they have a fever. And I asked them, are you sure you have a fever? They said, yeah, I do feel like I have a fever. And I'm like, but we just passed through the airport and they let you go? And so I was like, immediate, because we had just come from Uganda, I was like, you need to go to the hospital. Then they went to the hospital and the doctor said they didn't have a fever. So that made me feel comfortable, because I would have been, I was getting a little nervous that we actually went through the airport and they took the temperatures and they let him go if for sure he had a fever that was, above the temperatures above normal. So, but to get to your question, I think, as Prof. Abayomi has said, governance structures that are respectful of countries, whether they are African countries, whether we are international countries, we need to work as partners. So we need to work in a way in which both people in the local communities and people that are coming in, so our international partners that are coming in, can acknowledge and appreciate everything that goes on around whichever area they're coming into. For example, as you're saying, as she said earlier, if communities are not going to trust these people that are coming in, then the help they're bringing in might not work. But if we are working together over periods of time, and there are structures that even the international partners know, when we fly into Nigeria, the first people we see is the Minister for Health in Nigeria, and so on and so forth. Those systems then will help in mitigating this lack of trust that builds over time. And people will know that, well, yes, we have international partners coming in, but they are working together with our governments, and so we can trust them because the government is involved. And so personally, I think that one thing that we need to do as the African continent is, one, define our vulnerabilities. Two, define governance structures that are accommodative, whether it's regional initially and then building up to international and then global. Because when we have those structures, everybody would know what to do and what not to do, where to step and where not to step. Because without those structures, then things fall apart and people come in and things are not controlled, and the people that are expected to go for this care do not go for the care because they don't trust. And trust has been, is a word that I'm hearing out there in many of my meetings. Whether it's in the case of emerging and emerging infectious diseases, or whether it's in genetics, like the program that I lead. There's a lot of issues around trust, and can we trust each other? Yeah.
Thank you so much. I want to take it from that issue of trust and go to Dr. Abdul Salam. Yes, we are talking about trust. Trust is about people, if we're really talking about trust. And I've always had this passion about community engagement in healthcare's delivery system. And the question for you will be, how can community be part of responding to the outbreak? Because for maybe 2 years in Lagos, I was working with community people to monitor healthcare facilities and to do a lot of surveillance around what is happening, whether it is about maternal mortality, whether it's about the doctor coming to the health center on time and things like that. But when it comes to an outbreak, really, what will be the role of the community in all this? And just as we have said, the community need to trust the PHC itself to work for them, and they need to believe in it and to be able to work in such a situation to address those kind of outbreaks.
Thank you very much. Well, I would start response from the surveillance structure system that we have in the state. And the structure starts from the community informant. So that is to show to you the importance of the community in detecting and reporting any event public health events, including diseases. So it's a community informant that are closer to the people. They know their people, they know what happened to them, they have trust in those people. And these community informants include the traditional leaders. It includes those who you will maybe talk about traditional healers. You are talking about patent medicine vendors who are close to the community. You talk about those that are, we call traditional birth attendants. So those are people who are closer to those in the community. So they want the reports. And that is when they are linked to health facility within the community. So they report to the focal person for surveillance in their facility before it even comes to the government, the lower level, the local government, and then as well as the state. So at that level of routine surveillance system, the community is already engaged. So when you are going to have any suspected outbreak or any form of reporting that is clearly in excess of the expected, it will come from the community informant. And it will go to the focal person. And these are people who on annual basis are also trained. Their capacity are built on how to report and how to detect at their own level using even the local languages. So at that level, the community is already engaged. Now, at the level of the state, you have what we call Social Mobilization Committee. And this Social Mobilization Committee, SMC, they also meet on monthly basis. And we have representatives of the different community at the different LGA levels. So they meet there, they discuss. Ministries at that point in time who have relevant information to pass will go to that meeting and pass the information to them. And when you look at what happened during the Ebola period, the issue of communication and social mobilization is very, very essential. And that is why you have the mixture of those that are health educators, you have the communicators, you have people within the community who are also involved. As a matter of fact, that is one of the factors, according to what Dr. Jide Idris said, responsible for the control of the Ebola, because people are informed. And there is no communication you want to give. You don't come to the level of the community, you cannot get it. Then we have what we call Ebola alert. And this Ebola alert, they are the one that also give information using the social media. And then they do what we call damage control, because there are a lot of information going on. As a matter of fact, during that time, there are issues of using salt. If you use salt to bath, if you drink a lot of salt, you will not be able to get Ebola. If you take cola nut, bitter cola, you will not get Ebola. So all this information, the damages that they caused were controlled by communication at that level and using different medium, which include electronic, which include using of IEC materials and co. So as at now, using our biosecurity projects, we have environmental impact assessment done. But before the environmental impact assessment, the first thing we did was community engagement. We have to engage the community. We have to give them information about the project. They ask questions. They express their fear, their concern. And we corrected all the impression. And as at now, we have had close to 3 community engagement, bringing in people within the community, including those that we can also call community security forces and co. Everyone understood what we talked about. And I think it's essential for us to have effective responses, even preparedness and responses for any of these public health events.
Is it working? Okay, great. Community engagement is very, very important in the whole of these things. I think I have one more question before I throw it open to the participants to ask one question or the other. Anybody could answer this question. I've been imagining, maybe because I'm a climate finance expert. So for me, everything involves money. So, like, what are we thinking? How much are we thinking in terms of really preparing? Really, because a lot of people have been talking about health financing, blah, 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 blah. But health financing or financing the issues of outbreaks, they are two different things. Their outbreaks are things you don't really think it will really happen, but yet they come up. What kind of financing are we looking at? What is the magnitude of the money that we need? Because whatever we want to do in terms of containing these outbreaks, we'll spend money. And you heard what Dr. Jide Idris said, that he was asking for money, they didn't give him. But when there was an outbreak, money came out. So can we really prepare financially? Because in climate finance, we have what we call readiness. You must be ready to receive money. You understand? So how can you be ready financially to address this kind of outbreaks?
Can I try?
Anybody can try.
Well, maybe I will give it later too. Well, in terms of finance, I know it is huge, and but for me, I think the issue of governance is still very, very important. And I think having a very good institutional framework and policy is number one before we talk about money. If we have that, it means that we already have the stated guideline on what we want to do. Because when you look at the money now, you are talking about money for emergency preparedness and response to be on ground. But mind you, we should not every time be talking about responding. We should look at the aspect of strengthening the surveillance system on ground. Because even if you have money and you don't have institutional framework and you don't have a surveillance system that is robust and strengthened, and you don't have human resources that are capable, because another thing we should be looking at is the critical capability. Our critical capability is very, very important apart from the vulnerability. So if we have that on ground, then we move to the money. Well, Lagos State, because my reference is my state. I'll go back to Lagos State. For now, I know that we have budgetary provision for the routine surveillance system. We have budgetary provision for emergency preparedness and response. We have budgetary provision for biosafety, biosecurity, biocontainment, and those are in place. But again, I think I will leave it for my senior colleagues.
Anybody can still answer the question. Yeah.
See, Dr. Abdulsalam sounded very positive. But I like facing facts. And I just remember the professor who gave us a lecture on vaccine, EV, am I right? Mpofo. He was hesitant to give us a lot of information, but I could understand. But one thing I do know is that there's a lot of ignorance the people who are to support us do not have enough information, or they have their own priorities. And I believe it's incumbent on all of us to increase our advocacy to those people, because without it, they will never provide the money unless there's a disaster happening or fear. The reason why I'm saying is that if you look at Nigeria, for instance, look at the health account situation in Nigeria, it is horrible. A lot of the money we have is out of pocket. Government spending expenditure on health is extremely low. And a lot of it is going on capital projects that do not really add very little to what we need. The real things we need for surveillance, all those little things we did research and that actually give positive reaction, they don't understand. And that's why I believe it is us, no matter how hard it is, that we need to start impressing on them, getting people to advocate for increase in health. They can read all the papers. They're all under control of the economists who will tell you infrastructure that. The same people that say health is wealth, but when it comes to allocating the money, they totally forget health until they have disaster. So I think our job is actually trying to convince these people on the need for them to budget for health adequately. And one thing I realized again is that there's a lot of research work going on. A lot of professional, people do research. They have findings. But those findings are not available to those policymakers that can turn them to. So I think these are areas we need to work on fully, or else we'll all be wasting our time. This is my own little submission.
Let me just comment on what Dr. Abdussalam said. I agree with you in many ways. I think there are two things that we keep discussing at the academy. Is one, we need to be more harmonized on the continent in everything that we do, including this kind of responses. Although we don't really want to be reactive, if it would be better if we were proactive. And that takes me back to a very important question that Alan asked yesterday. And I'm not so sure that I'm convinced that it was fully answered, because it's a question that we would like to follow through. When he asked about, do we have enough data to do our own modeling so that we can be prepared in terms of taking action way before some of these things potentially happen, if we can model and know what's going to happen tomorrow. So that's a question I just want to leave out there to the group to be thinking about. And that will involve having the right skills so that we can mine our own data. I don't know what's going on in DRC right now. I don't know who is collecting the data there and how it's being governed, and who is, or whether the data is going to go out and then come back to us to tell us exactly what's happening and what we can do tomorrow. So that's a question that we need to be asking ourselves. The other thing is, going back to harmonization, I know that the African Union, for example, the member states are supposed to be giving an X percentage of their GDP into research, but they haven't put that money into the research bucket. But is this something that we need to be pushing to the African Union so that we can have a bucket of money for, even if it's just the equatorial region where we know that these things are a problem? Because if an outbreak is occurring at the border, who is going to respond? And why should we wait people to come from elsewhere into DRC when Uganda has been dealing with Ebola in the past, and they probably have the right skill, but we are right there, but help has to come from elsewhere. How can we use the skill that we have locally, and by locally here I'm talking about the continent, to deal with these issues and to contain them before we seek help elsewhere? Those are just questions that I'm leaving to the audience also to be thinking about. Thanks.
Do we have questions?
Sorry, I just wanted to comment before you throw the floor out. I think it's important that we understand that preparedness is a frame of mind. It's a culture. And there's no difference between an acute response to an event and a well-prepared public health infrastructure and system. So if you have a public health system that is robust, then responding to an outbreak would be a walk in the park. The reason why we're struggling in Africa is because we have very low infrastructure, very low human capacity, and very low awareness at the political level. So what we need to do is, and these are systemic preparations, it's not just how do we respond to Ebola. There's a whole sequence of events that happens in the public health sector that enables you to respond adequately to the smallest surveillance trigger before it becomes an overwhelming event. What happened in Sierra Leone could have been nipped in the bud in 1 week if there was a culture of preparedness.
Can I comment on that as well? Yeah. I think you guys are letting the international community off way too easily. So I'll say this because it's about governance, but it's also about international governance and the global community's response to this, because we are, as a globe, a culture of response and not a culture of preparedness. So even as the way the funding has come in for with these outbreaks, whether it be West Africa epidemic or the current DRC, it's always delayed. It's always, it's always after. It's as if in West Africa, the epidemic, Ebola said, I'll give you a chance to control me, and we didn't. And it's the same thing with DRC. It said, I'll give you a chance to control me, and we didn't. And I'll tell you, in Sierra Leone, in August was when the public health emergency of international concern was declared. By the time majority of the financial resources that came from that emergency declaration came on the ground, it was November. If you remember, that's around the time the cases started dropping as well. I mean, there have been maybe other reasons for why it dropped, but what it was like to work in Sierra Leone during that period, when you have an earthquake, you build your EOC, you have your response, you have your security, your treatment, you have everything, right? Now, what if you have a situation where your epicenter is this one place, but 1 month later, your epicenter is over there, and 3 months later, your epicenter is over there, and you have so few resources to begin with, and now you're spreading those resources and chasing the tail of the outbreak everywhere, which is what was happening. Everywhere we went, a few months later, the epicenter was in Kenema in August 2014. It was in Port Loko in November 2014. And so, yes, there needs to be local preparedness because the foreign response thing just doesn't work. We're always delayed. We're always behind. It needs to be for the reasons of trust that we talked about. But the way that the international communities always put money on this is we have responded. And even some of the big gains that we had, investment in global health security, investment and creation of the World Bank's pandemic financial utility, even those are not panning out as we thought they would. They're going a little way, and a huge part of that is our political dysfunction in funder countries as well. Our White House just started, just threatened to cut foreign aid that's going to have impact on all the stuff that we're talking about on a whim of one politician. If we can let you're talking about lack of governance here, there's lack of governance, I think, internationally as well. So I think that's a huge part of where the money and connection with governance comes in too.
Thank you very much for those responses. Do we have questions? How many hands do we have up? I think, maybe I should start from, a lot of hands. Okay, let's take number 1, 2, 3, which other hands? 4, 5. So, 6. So, number 1. Number 1 is here.
Thank you very much. I wish to commend the panelists for doing justice to the topic preparedness. Talking about finance, the former Commissioner of Health, Lagos State, talked about the issue of low budgetary allocation to finance, to the Ministry of Health. You see, the problem is not only low, but in Borno State, we found a big gap when we were doing a budget tracking between what has actually been approved and what is actually being released to the ministry. So we have to take note of that. It's a very serious problem. And then the other issue is from the experience in Netherlands and Denmark, the dairy farmer in the village, the university knows the existence. The Faculty of Agriculture knows a dairy farmer in the village. So there is a sort of networking partnership. In Borno State, the vegetable farmer in Alo, which is 25 kilometers away, does not know the Faculty of Agriculture in the university. And the faculty does not know the existence of the farmer in Alo, which is about just 25 kilometers. I'm coming to the issue of data, and that is why I'm bringing this scenario. Data and research, they go together. And it's one of our fundamental problems in Nigeria. We don't have the data. So planning in health or any other sector is practically impossible unless we have data at hand. Is there any connection between the Ministry of Health and the Faculty of Medicine in the universities? If you go to the universities, in all the faculties, all the departments, you see students' projects that are lying there. In some cases, the termites are taking toll on them. So there is no connection between the government agencies and the universities, and of course also the research institutes. Is there a link between the Ministry of Health in Lagos and the national, that may be true, but for some other states, do they even know the existence? So unless we create this synergy, I think there is still a problem. We are not addressing the issue of data and research, and we have to leverage on what the universities and research institutions are doing so that we create a synergy. And then finally, the issue of even the public-private, I think is very important. Most of our local people patronize the local private health outlets. What are we doing about that? Let me just stop here. Thank you.
Thank you very much. My name is Shino Fagbero. I work with Mother Gold. On the issue of funding and funds availability, I think there are two sides to it: funding preparedness and funding an eventuality. There are things that we appear not to have keyed into. The SDG 11 talks about building resilient cities. And part of what resilience is about is to ensure that a city or a hub of human population that can quickly respond, that has all the built-in, the way you build, the way you have access to roads. There are some cities in Nigeria, for example, I mean, people boast that they are large cities, but to penetrate, if there is a fire in a place, the fire engine cannot get, will not have access because the roads that lead there, you know, or there's no access to water. So I believe that there's a lot we can do to key into the SDG, particularly SDG 11. Let's make a target of building a certain number of resilient cities within any region or country. The second thing, in terms of, okay, when it happens, how do we respond? I know that there are funds can be ring-fenced. You know, nobody plans for, nobody prays for it, but it happens. I know the World Health Organization has some kind of facility through the CDC or something that actually attracts funding for eventualities like health disasters. There are templates too in places like the US. Lastly, the security votes for the governors and for the president is not supposed to be for guns and bullets and to be able to ensure that nobody shoots the president or the governor. Security votes also happen, that what security votes should be should also include disaster eventuality. Finally, I don't think we are monitoring our NEMA. Nigerian Emergency Management. I'm not sure whether that program has had a review since its inception. So there's a continuous effort, and there is an effort that prepares for spontaneity. There is also how we plan, particularly leveraging on things like the SDGs. Sorry, it was a comment, not...
Yeah.
Thank you very much. This is a very interesting debate. I'm confident that since the epidemic in 2014, 2015, many things have been improved into the 15 ECOWAS countries, and I'm based at the West African Health Organization, and I can assure you that many things are done currently to improve both the surveillance and the response in many countries. But many things are done, yet I think there's still a lot to do. For instance, I think that the thermal cameras that are in all the airports now were donated by WAHO. My concern is rather in regard with the discussion with the community involvement. I'm afraid that what's going on in DRC currently is not by hazard that is during the pre and post-electoral period. And because they've already had several Ebola epidemics that they were able to control. And my feeling is that part of this problem that started in Beni, which is not far from usually it occurred, and where there are well-trained teams that people are used to manage this kind of epidemics. There's more and more lack of confidence, and that the instability among the government, and the fact that now recently the Minister of Health resigned, that there are conflicts between the people who have responsibilities to to follow the epidemic is also part of the problem. There's a big lack of confidence from the communities. And I'm wondering what would be going on if we had such epidemics in regions, in all countries in the ECOWAS region, where we have a similar situation. Unfortunately, if you consider now my country, in Burkina Faso, in the north of Burkina Faso, there's an unrest situation that lasts for many months now. And no, I don't have to mention Mali and the north of Niger, so north of Nigeria, obviously. So we have to consider this problem, and certainly we have to try to involve more and more the communities, try to get them part of solving this problem and being part of the surveillance. I understand that you say that you're trusting the communities to signal traditional healers to alert if there's any problem. I'm not sure it would be the case, I'm afraid.
Number 4.
Right. Thank you, distinguished panelists. My name is Dr. Edwin Isotuhede from the World Health Organization. I'm so excited that this is a very serious issue, especially here in Africa. Mine is not a question, it's not an interrogation, but just a few suggestions I want to make. As a matter of urgency, I think we need to make the primary healthcare system in Africa to work. Primary healthcare system is not primary healthcare facility, but is a system. It includes both the community and the people that live in the community. I'm so happy that they mentioned the issue of the first responders. When the people, the local people understand that this, if they have a specific health issue, This is the point where they go to report. This is where information will be disseminated. We have very few work to do at the higher level. But until we make the primary healthcare system in Africa to function effectively, to work effectively, it will be difficult for us to be able to respond to a lot of biosecurity risk and also the threat from emerging and re-emerging pathogens. Secondly, I am excited. Yesterday, I learned Dr. Chikwe from the NCDC was part of this program, and he can attest to the fact that leveraging on multi-stakeholders' ability is a very efficient way that we can be able to make progress in Africa. Don't just public health emergency is very, very expensive to respond to, and it does not require just the expertise of only the health system. All those other systems have to work together, including environment, including agriculture, including information, including education. And most of the time, when we're addressing these issues, we look at it from just a health system point of view. And that is where we're missing. Most of the solutions that we need, it is from the non-health sectors. And it is one of even the key issues even we're bringing on table at the end of the WHO. And I think we're making progress in that aspect. Because when, I'll give an example, in April, there was a research team in US linking with some experts here in Nigeria, and they discovered that 3.3% of the Ebola of bats, of monkey in southwest Nigeria is positive to Ebola. And this is coming from agriculture. So if we are just looking at just the health agenda alone, we're missing a lot of people, a lot of expertise that will leverage to address the problem we have in the continent. And lastly, I will say that is a personal opinion, not my organization, is that professionals in Africa, experts in Africa, leaders, innovators in Africa, we need to move beyond the bench. We need to move beyond our desktop. We need to be in the political space. Because it makes no reason for a professor in very high level issues who understands how things work to go and be talking to somebody who does not understand, who is sitting up there at the corridor of power and who find it difficult to release money to address problem. So why can't we vote the people who understand the problem to be there in power? Why can't we synergize to make sure that we put the people who understand the problem? And until we have a paradigm shift from this angle, all of us, we're talking to the same people that understand the issue, who are experts and all that. Meanwhile, the people who don't understand the issue will be somewhere sharing the money. And I think it's a radical approach that I think that we need to begin to think in this angle if we must sustainably address the issues we have in the continent. Thank you.
Thank you very much. I think number 6, if I'm correct.
First of all, I would like to say thank you to the panelists. This was actually a very interesting discussion. I enjoyed it a lot. And I know that most people across Nigeria would agree that Ebola was controlled in Lagos because it was Lagos.
Really? Okay.
Yeah.
A round of applause for Lagos.
Yeah. Yeah.
So what if it was not in Lagos?
Nobody knows what would have happened. And on another side, we would say we're glad that it entered through Lagos, and then the Lagos team were able to respond as fast. Because we are not sure if people in other parts of the country would actually have been as proactive as the Lagos team in curtailing it.
Maybe.
Yeah. So, I know that in airports now we have a lot of thermal cameras scanning people's temperatures and so on and so forth. But in Nigeria we have a lot of unmanned borders. And these borders, there are lots of human movement across all of these borders into and out of the country. So, is there any specific intervention that is looking at this particular unmanned borders? Yeah. And then my other question is directed specifically at Dr.
Hello?
Nadia.
Please, let's listen to the question.
Yes.
Your question again, please.
Yeah. Is there any specific interventions that we're doing now that is looking at these unmanned borders? Because although maybe many people come into the country through airports, but a huge number are actually crossing these borders as well. And then so my other question goes to Dr. Badia.
Dr. Badelia.
Badelia.
Yeah?
Sorry for pronouncing it wrongly. So from your presentation yesterday, you actually showed us some new units that you're using in Uganda that is improving the way clinicians are actually able to make contacts with clients. But I don't know. Could you shed more light on how much units like that cost? Because the existing one now, I know that the system is a bit used to that one, and then they know the cost. But the new one, your test running right now that improves contact might be more expensive or might be cheaper. We don't know. So if you could shed more light on the costs. Thank you.
Thank you very much. So, who wants to go first? We are taking note of these questions.
Good afternoon all. I want to say a big thank you to all the panelists and my condolences, sir. I'm sorry about your loss. I was actually excited when he mentioned it because I just finished discussing with some people on my table. It's my own personal view that if Ebola had happened anywhere outside of Lagos, it would have been a different story. And I used my facility as an example. I said, imagine if he was there and he told the doctor, please let me go. We just give you your sign. You sign. You want to go, but sign no. You sign and you go. But she insisted, you are not going anywhere. But mine is a clarification to Dr. Nahid. She mentioned something about the new cases of Ebola not being from any known contact. And something about it happened with the health personnel. Please, I want you to explain more. Thank you.
Good afternoon, the panelists and everybody here. I just want to make a comment that they said health is wealth. And if health is wealth, driving the health of any community is fund-driven. And I stand to be corrected. There's this mentality that most governments within Africa, or should I say Nigeria, we have this donor-dependent syndrome. In the sense that we've not actually placed so much priority. That's the government itself. It needs to look inwards on how to fund many of these institutions that deals with public health emergencies. Because we can't always wait. Let's deal with our problems ourselves. If it's overwhelming, then we can call for external help. And I must also say here that no state in Nigeria is immune to public health emergencies. But I must commend the state of Lagos for being proactive. We don't need to wait for emergencies to come before we start acting. But from what Dr. Abdul Salam said, that is, they've made budgetary allocation for surveillance, budgetary allocation for biosafety and biosecurity lab, and as well as emergency preparedness. I think it's something that deserves commendation. And I want a situation where in next conference, we hear more about Lagos State here, and we should, other states should be invited, because if emergency happens, it's going to go beyond just Lagos State. Thank you.
Do we still have more questions? Or even if we have more, can we just answer these ones before we go for, if there's time, we can go for another set. So,
I'll briefly answer the two questions. So the units that Alima is using, called the Cube, those are being used in DRC, and they've been used for the last 8 months or so, as far as I know. They're not cheap, and they're not the answer in the long term, but they're proof of concept, which basically says we can change the way we provide care to Ebola patients. So the unit we have in Uganda, what we've done is just made one wall made half out of glass, so we can monitor patients better. So it doesn't feel like an enclosed space. It feels like a clinical space where you can observe patients continuously. Your question about the new contacts, so the 50% of the new cases that they are coming across, patients who are coming to care, they're discovering that these are patients where they don't know where they got their disease. So the way that we trace, as you know, new cases of Ebola is we follow someone who has the disease, we look at all their contact, and we make sure that none of their contacts develop disease. That means 50% of the new cases aren't coming from contacts we're following, they're coming from people we didn't know. And so we don't know where they got their disease. That means they may have gotten sick from someone else that we haven't even caught yet. And that's a dangerous situation. It means there are tons of cases that maybe are out there that we potentially are not picking up in time. 11% of the cases are from people going to get regular medical care. Ebola looks like any other disease at the beginning of the disease. In the first few days, it looks like malaria, it looks like typhoid, it looks like, yellow fever. People are going to hospitals and community health centers and maybe potentially getting Ebola from other patients who might be there seeking care, or they're getting it through potentially lapses in infection control within those health facilities.
Well, the question on link between the Faculty of Medicine and the Ministry of Health. Well, for Lagos State, I think Lagos State should be a model because for most of our activities, we have so many committees that are driven by people from the academia. And Professor Akinbayomi is a consultant to the state on the Biosecurity project. Even as far back as the time was professor at Stellenbosch University. Professor Alan is also one of our facilitators as far as bioinformatics is concerned, and the lab information management system. We have trained personnel at the BBT. We have Dr. Wright here from Lagos State University, College of Medicine, and always attending a conference with us. Dr. Mutiu, that we have moved to our own side, is also from the same institution. Professor Omilabu is from College of Medicine, University of Lagos. Professor Oshibogun, though not present here, is also a professor of public health, and they form the B4, the Biosafety, Biosecurity, Biocontainment Committee. Then we have LASMATAC, the Lagos State Malaria Research Program. We have people from Nigerian Institute of Medical Research. They are here. Dr. Rosemary Audu, Dr. Musa is here. We have Dr. Adewale. We are all collaborating in our... So we have very effective collaboration with all the institutions, even outside Lagos, from University of Ibadan as well, and outside Nigeria. So the collaboration has assisted the ministry in moving forward. And as a matter of fact, our policy development, our legislation, they are only part of it. And I remember the commissioner will say, have you shown it to Professor Abayomi? What did he say? For you to see how much importance we give to the people in the academia, people from the research institute as well. Now, on the issue of the border, it's very difficult. Nigerian border is very, very porous. And as far as point of entry is concerned, we have issues at the Grand Crossing. Because I know that we have some organization, WHO, Pro-8 International, at the international airports in the country. We have Muritala Mohammed Chanapi of Lagos, Abuja is there, Kanu, and the other one. We have 4 of them. Their public health contingency plan has been developed, involving all the stakeholders. Just about a month ago, we have a delegate from World Health Organization, AFRO, and also from Nigeria, with those of us that are here in Nigeria, the state epidemiologists and co, and the Port Health Services, with including Federal Ministry of Health, the IHR focal point. We have assessment of the point of entry that were designated. And we visited the Seme border, which is for Lagos State, a very big border where you have a lot of good and human resources coming in. So assessment was done there, but it's very difficult. We have so many points at the Grand Crossing. But what is interesting is that as at now, we have public health contingency plan at those borders involving all the stakeholders that are there in terms of responding to any form of public health emergency, including the Badagry local government within the state. So a lot is being done in that area, but the issue of the porosity of the border is something that we still need to fight on.
Maybe I'll take the question that Olivia asked regarding the ability to respond to an outbreak that occurs in a conflict zone. I think you are speaking lowly, but I think that's what you were asking. So let us just presume now that there is an Ebola outbreak in the northeast of Nigeria, in the area that is under siege by Boko Haram fighters. Would we get the same amount of response, either from indigenous preparedness teams or from the international community? I don't actually know the answer, but obviously it will be less than we would have gotten if it was somewhere else that did not have the stigma associated with terrorism, violence, and conflict. So what does that actually mean then? That actually puts emphasis on the fact that we must be reliant on ourselves to respond to outbreaks. Because if you get an outbreak in a conflict zone within your country, nobody's going to come in to help you. You've got to respond to save your own people, which means there is an emphasis on indigenous capacity. And I think someone else mentioned that in the crowd, that we should be able to respond to our own crisis, and if at some point it becomes overwhelming, then we ask for international assistance. So I am a great advocate for indigenous capacity. We should be able to respond. We need to build, as you heard, resilient cities. We need to build robust public health systems so that you detect things early, you respond early, there's community awareness, there's a multifaceted response to a situation that brings it under control quickly. What Dr. Abdul Salam was describing is true, but it is true, in my opinion, in a localized fashion in Lagos State and maybe 1 or 2 surrounding states. I can't say that that same response and preparedness modality is going on across Nigeria or in fact across the continent. This is an African conference. Half of the people here are from Lagos or associated with the teams that are operating in Lagos. So this is very much a Lagos event happening in Abuja. Where are all the other states? Where is the representation from the Federal Ministry of Health? Well, we have NCDC because We had the chief executive here yesterday. Where there are 36 states in Nigeria. Where are they at this meeting? And we're discussing issues of national importance and national security, and they're not here. So, I don't know, Lagos is not the norm. Kudos to you and your commissioner. And for the Lagos team, I mean, actually, I would like this meeting here to give a big round of applause to the Lagos team. They're all here. They paid for themselves. And when you talk about political will, when a number of professors and professors in the crowd came to speak to the chief executive, who was the representation of the government, he understood. And he said, yes, we need to do something. We're not going to live through another experience like we experienced during the Ebola outbreak. It's not going to happen again. That is political will.
Well, Akin took the words out of me. There's localization of all this happening in Lagos. And I want to dwell on research and policy. Yes, all these professors were talking about either personal friends or people who forced to co-opted into this. But I attended a conference last month on cardiac diseases. And this nice professor gave a nice presentation on the causes and what. And we sat on the table and I asked him, these findings you have here, have you released it to government people? He said, oh. You see, that's where the gap is. But it's the same researchers abusing government officials that we don't know what you guys are doing. So and so, but we need to share this knowledge. So we need to bridge that gap between the town and the ground, what they say. How we do it again is education from both sides. That's what. Sheena mentioned the issue of resilience. I think in this country we have a way of doing things in silos. Again, I was supposed to make a presentation today. I declined on biosecurity in Nigeria. And the reason being that there are many agencies of government at the federal level who are doing one thing or the other on biosecurity, but I don't have access to that information. So if I present anything, it's just going to be localized to Lagos. That was the reason why I said I would not present until I get all this. But it's very essential. And that's why, again, we all need to start working together. We need to make serious advocacy of what we are doing here to the various governments. Which also brings back to the issue of porous borders. I remember during that Ebola thing, there was a truckload or a bus that got into the country through Kwara, one border in Kwara State. And the next thing they said, they called us Lagos, can we please come and take care of this? And I said, are you mad? I should leave Lagos and come to that place. You see, just so that, look, no matter what we do, we have to build capacity at the various states, or else we'll be wasting our time. You understand me? Because if you went to the border in Kwara State, they know the terrain. We don't. Now, if you expect the federal government to respond, they cannot respond adequately because they don't have the manpower. They still have to call on those people at the local government level, local level too. So we still have a lot of work to do to advocate to all these people. We have serious issues. And I think a lot of it is due to serious ignorance. Ignorance too amongst our professionals, ignorance amongst government or policy makers. And maybe you said knowledge sharing, right? The aspect of it is knowledge sharing. Knowledge management. I think we need to focus on that too. Thank you.
I want to say a big thank you to all the members of the panel. And as we are leaving, there are just a few things I penned down. that I hear them saying. Preparedness is a frame of mind that I got. And it means that it depends on us. When things happen, what kind of action do we want to take? So it takes a prepared state of mind to really respond to outbreak. And then we need a robust public health system. And that is what I hear everybody say here. And it means that if we have that kind of public system, then it's a system that is tested, and if in that testing in outbreaks, it means that we become resilient as we continue to fine-tune and do what we need to do within our health system. And then I hear about ensuring that we work together with all stakeholders to find solutions to all the health problems that comes before us. These are very important issues we need to take out from here. I want to say a big thank you to all the panel, all those who spoke in this panel, and I really appreciate all the insights you have given unto us here. And I want to also say a big thank you to the participants and those who asked questions. Thank you very much. You're welcomed.
Okay. That was the panel on preparedness. I would like to appreciate the moderator. Please, before you leave, hello, Madam Moderator. Hello. Yes, you did a fantastic job, and I thought they should appreciate you for that. Thank you. Okay, thank you so much. We are moving into the country progress reports on biosecurity. We have 4 countries listed, but at the moment we are only going to take 2. We are going to take Lagos, and we are going to take Sierra Leone. Lagos is a country. So I don't see Lagos as a state. Lagosians, Nigerians may see Lagos as a state, but each time I see Lagos, all the advancements being made in Lagos, how they are tackling their challenges, they are facing their issues, how the GDP is next to Nigeria's GDP and all of that, I don't deceive myself. I don't delude myself to say Lagos is a state. And from Ekiti State to Ekiti, Lagos is a country. So, we will invite the presenter, Dr. Bankole. Is he in the room? Who? Sorry, where is Dr. Bankole? Dr. Mutiu, sorry. I have Dr. Bankole here. It says Dr. Bankole and Professor Abayomi. So that's why, okay. So Dr. Mutiu, we have Dr. Mutiu. And then for Sierra Leone, we have Professor Sarah Jivao. Is he in the room? Okay, sir. But before I invite Lagos, the organizers would like you to check your name tags to confirm that your names are spelled correctly, because that's what will be on your certificate tomorrow. So kindly check if there is an error. Please draw the attention to that error so that you don't go home with the wrong name, so that we don't have a crisis on our hands tomorrow with wrongly spelled names. So, Dr. Mutiu. Oh, okay.
There is this thing called peer learning, peer review. Do states have that mechanism for learning from one another? I'm talking about the situation of Nigeria. I know this is what's going on right now in this room, that we are learning from one another, across countries. But does it happen in Nigeria that somebody from Plateau will go learn from Lagos, for instance? Lagos team, does it happen? Okay. Okay, is Sierra Leone ready then, if Lagos is not ready? Is this the one we are taking now? Are you ready? Okay. So you have 15 minutes. Then Sierra Leone too will be 15 minutes. Then we'll take questions on both presentations.
Good afternoon, ladies and gentlemen. I'll just be giving Dr. Bamidele Mutiu, a member of the Lagos State Biosecurity Project and the director of the Lagos State Biobank. I'll be giving just a brief overview of and the timeline of the Lagos State Biosecurity Project in the past 2 years or 3 years. Slide. Okay. I'll be going through this outline. I'll give a background and critical vulnerability of Lagos State, the existing countermeasures against biological threats pre-EVD outbreak in 2014, then the post-EVD containment activities that were done, and the collaboration of Lagos State with GPP Canada, the current activities of the biosecurity initiatives. As you all know, Lagos State is the smallest state in Nigeria with an area of just 3,577 square meters, with a population of about 24 million people. Very small, but highly populated. And is the commercial, the financial, and the industrial nerve center of Nigeria as of today. Lagos is a mega city. It enjoyed the status of a mega city, but the challenge of Lagos is that even though it's a mega city, there are some things that you see there. Let's just look at the advantages that we have there. Number one, the political commitment is there. There's a vision to make Lagos an economic magnet that will attract people from every diverse background into the states. There is a policy direction, environment, transportation, security, housing, healthcare, safety, infrastructure, Then there were planned incident management approach as well as rapid response system. This is Lagos State. Next slide, please. Okay. This is Lagos State that I'm sure several of us are aware of, that we see almost on daily basis. Whenever you are approaching Lagos State from the air, you see this beautiful city, and you look at it, this is a wonderful place to be. But this is another Lagos State that you may not really be conversant with, that we deal with on regular basis. And another thing, with this small area that is densely populated in human density and the mental stress. So that one alone is a challenge to us as a state. Now, before Ebola, there has been several outbreaks of infectious diseases, right from as far back as 2007, when we have avian influenza. Whatever the outbreak that you've ever had to deal with on international level, Lagos will have had 1 or 2 cases, be it avian influenza in 2007, cholera, Lassa is almost on a yearly basis, the Ebola virus disease in July to October 2014, avian influenza in 2015, measles, Lassa, then multi-drug resistant organism, enteric pathogens in the secondary school. That was in February 2017. Lassa fever is always on yearly basis. And as of now, we have about 8 confirmed cases of monkeypox as of now. And not only that, we still have the issue of the circulating vaccine-derived polio virus being a challenge with Lagos State. So there were some existing countermeasures against biological threats pre-Ebola virus disease outbreak in 2014. And there was the establishment of Lagos State Emergency Management Agency, LASEMA, that was backed by law. And then we have the LASAMBOS, Lagos State Ambulance Service. There's a functional and effective emergency preparedness and response committees in all the tiers of healthcare delivery. There is an existing infectious disease hospital. That is the mainland hospital, and that is the only infectious disease hospital that is a standalone infectious disease hospital in Nigeria as of today. Then the enactment of the public health law, as well as the coroner's law and crematorium at mainland hospital. Then there's also the establishment of a viral integrated disease surveillance response system. You heard one of the panelists talking about the community informant. Apart from that, when the WHO supported state by giving every state about 10 disease surveillance nursing officers, what Lagos did was to employ more, so that for every local government and local government development area, you have a disease surveillance nursing officer. So, and that one was paid from the Lagos State purse. Then there's the effective collaboration with state and federal institutions, and that was one of the things that helped us during the Ebola viral disease outbreak in 2014, because the first diagnosis was made at the federal teaching facility, federal hospital, teaching facility, that is the Professor Milabu's lab in Lagos State, Lagos University, University of Lagos. Then the establishment of SEMO, we've already heard of that one. After that, those were the existing measures. But then the Ebola struck in Lagos megacity in 2014. We had 20 cases, 8 deaths, and there was outcry all over the world that Lagos had really done well. Because when you look at it, the issue of what would have been the issue if the virus was able to go out of control. Averagely on a daily basis, the number of flights that leave Lagos should be close to 100, and minimum number of people that leave Lagos to different countries all over the world is between 5 to 10,000 on daily basis. So you can imagine the number of people that will be infected. Now, post EVD, what did Lagos do that was able to birth the biosecurity project that we are talking about now? The first thing was we had the state Ebola virus disease research initiative that later became a committee. And what we were doing what we look at was what was the progression of those patients that were treated during the outbreak that survived. How then we wanted to see were the virus still in them. Then we wanted to look at the antibody level. Maybe it's something we can harvest. and be able to develop even immunoglobulins that can be used later as treatment. And then later, by 2015, we were able to attend the first African Ebola conference in Senegal. That was the first GETS conference. After that one, there was the hosting of the second African GETS conference in Lagos State. And the advantage of that second GETS conference was the partnership that now came into being with GPP Canada. And we were able to, with discussion that we enter into, we were able to get a BSF-free facility that was facilitated by GETS Consortium. This was the picture of the most of the people at the opening ceremony during the second Ebola viral disease outbreak. The GETS conference in Lagos. You can see that we have people from diverse background. Even the military was involved. So the issue of security is very, very crucial, because during outbreak you need a security agency for ease of movement, for protection of the healthcare workers, for the protection of the first responders. So everyone was involved. Now post-outbreak, we have the GPP Canada sponsoring the design, the construction of the high consequent pathogen BSF-free laboratory, and as well as a biobanking unit. The biobanking unit came into being because we are looking at the issue of benefit sharing. And one of the things we want to do, we were saying, is that we are no longer going to fold our arms and allow every samples that were used, that were diagnosed, that were positive, to be shipped out of the African continent. We want it to remain here. We want all the researches to be done here. And even if you are going to take the samples, we want to be able to account for it. Then the issue of benefit sharing comes in. Every product, every diagnostic kit that were developed as a result of those samples being shipped out, there must be benefit sharing. That is one of the reasons for the biobanking unit. Then there was the installation of the facility as well as supply of equipment. The biobanking facility we have is able to diagnose. Not only that, we have at least PCR machine, the conventional and real-time PCR. We also have a sequencer, so we're able to sequence. So it's not a question of taking anything outside Nigeria. The Lagos State government too did counterpart funding, which involved capacity building of the personnel, the maintenance of the laboratory, community engagement, and there was also an environmental impact assessment. Why do we really need the Lagos Biosecurity project? Number one is to improve security. Remember the vision of Lagos State to be a magnet that will attract as many people. We are looking at Lagos as an economic hub, and if there's improved security, there's improved assurance that people will come in. There will be, and then with Lagos Biosecurity project, we are increasing emergency preparedness. Then we wanted to, another reason for the project is to protect our reputation and image as Lagos State. They will tell you, okay, you can go to any other state, but you can be rest assured that if you are in Lagos, you are safe. So we want to tell people that when you want to do business with us in Lagos, you'll be safe. We'll be able to mitigate liability when it comes to exposure. We'll protect public health. We'll protect our employees, and we also protect research. So research will be done responsibly in a safe environment and will be ethical. That is the reason why we have the Lagos State Biosecurity Project. And these are some of the timeline of activities that have been done. The approval of the collaborations, then the conduct of the environmental impact assessments. There were modular training on biosecurity and biosafety for the LBBT. LBBT stands for Lagos Biosecurity and Biobanking Team. And we are about 13 now. We are 13 in numbers, and all of us are present at this conference. And each of us sponsor ourselves to this conference. I believe we deserve a round of applause for that. So if you are a member of the LBBT, just say hi. Members of the LBBT, just say hi. So they are seeing you because this is being transmitted real time. The appointment of a consultant to the Lagos State Biosecurity Project was also done, and workshop on biobanking and security module. There was a community engagement, setting up a technical committee, as well as manuscript development on Lagos biosecurity and biobanking project. Draft policy. I can boldly say that the only state in Nigeria, including the country that has a biobanking and biosecurity policy, is Lagos State as of now. We've already developed our policy. It has gone through validation and it's undergoing another set of review before we'll bring it out. Then as part of our emergency preparedness, we did a framework and roadmap for a coordinated response to biosecurity threats on the 8th of November last year. Then there was also a policy review on biosafety. Then the issue of One Health came into being, and we were able to inaugurate our own Lagos One Health team that brought in the people from Ministry of Environment, from Agriculture, and we included those even from the judiciary, because we recognize the impact of laws and on responses. And when we during one of the legislative review, we discovered that the only quarantine law that existed in Lagos, that existed in Nigeria, has been existing for close to 100 years. That was the one that was brought in during the colonial era, when you travel between Nigeria and every other country outside Nigeria, it had to be by ship. That was the only law in existence. So there was no law talking about quarantine and isolation and the rest. So legislation review is still ongoing. Then there was the official commissioning of the Lagos State Biobank on October 38, 2018. And the person that did the commissioning was the Governor General of Canada. She came with the then Governor of Lagos State. Then the Lagos State Biosecurity Initiative, civil engagement was also done. And then the training of the biobank team, LBBT continued with the biobanking and LIMS benchmarking that was done between 13th and 18th of December 2018. These are some of the pictures of the participants at the biosecurity and biobanking workshop, 28th to 1st of May, 28th of May to 1st of June 2018. Community engagement held on 14th June 2018. You can see that the person seated there, the police officer, happened to be the DPO overseeing the particular environment where the facility is situated. So we engage everybody. This is the biobanking, the LBBT, as we used to call ourselves. You can move on. Yes, next one. Okay. Next. Okay. No, please, can you go back a bit? Okay. Then the facility itself, during construction, oh, sorry, the lighting is bad. So you can see this is the outside system, the feature system that we use Bibo, bag in, bag out. The final, okay, don't worry. The inside of the lab itself, you can see that anybody that will be motivated to work in this kind of facility, this is official commissioning by the, you can move on. Yes, the official commission, that's the Governor General of Canada, the then Commissioner of Health, Lagos State, the then Governor of Lagos State, Governor Ambode. You can move on. People from the academia, most of the people there are from the academia, the former PS, Professor Shibogun, Professor Milabo, and the rest are there. Recent activities that will be finalized, there will be technical training of the LBBT on use of the Lagos State Biobank by AFMS, South Africa. Then 2 of the members of the LBBT are already certified professionals in biorisk management. This was done through the exam, IFBA, International Federation of Biological Biosafety Association. And the pass mark for that exam happens to be 74%. And I can tell you that the 2 of us passed very convincingly, very, very well. Validation, myself and the manager of the facility, we were the 2 that went and we passed. So hopefully this year, the other members of the team will be able to do their own. Then validation of the biosafety and biosecurity policy has been done. Finalization of the legislative review was done 14th to 17th May 2019. The One Earth paradigm was continued, and the One Earth State Lagos team was launched. Next one, please. This is the One Earth theme, Lagos State. We have people from the Ministry of Health, from the Ministry of Justice, from Agric, and ongoing activities, technical training of the biobank personnel by GET Consortium and GPP Canada. We are hands-on training on sequencer and Minisec. The biosecurity governance is still an ongoing one, and we are waiting the inauguration of the Governing Council, as well as training and orientation of the council members. And finally, we are believing that presentation of the bill on biosecurity and the enactment of the bill into law. This is just a picture of the training on baobab limbs. I'm sure Alan will easily recognize himself there. Training on RT-PCR. Finally, way forward, which is my last slide, is sustainability. We are looking at bioeconomy, the issue in which we are able to, whatever you need when it comes to organisms, tissues, and the rest, because we'll be able to bank it very well. We are looking at sustaining the facility through bioeconomy, then public-private partnership, then commercialization of research that are done there. Then there's going to be research collaboration through grants, direct funding by the state government, and creation of an agency on biosecurity, as well as the strengthening of the One Earth paradigm. Thank you very much.
Thank you. I'm surprised that the Lagos delegation didn't give you a standing ovation. I was expecting them to do that, because that is the, you see? That is the Eko Nibaje spirit. Did you notice, participants, remember I said Lagos is a country, right? Did you notice that this last presenter was the only one so far in 2 days that has demanded, he demanded that we put our hands together for him. Did you realize that? They are still doing it. They can show off. We know you very well. But that was a very great presentation, and that also speaks to the fact of what we've been talking about in the past 2 days, that political will is very essential to move any state or any country forward. So I'll invite Professor Sahar Jival from Sierra Leone to make his presentation. You have 15 minutes.
Biosecurity updates, really. Yes, good afternoon. The biosecurity project in Sierra Leone is very similar to the one in Lagos State. In fact, we started first, but ours have lagged behind mainly because of the change of government. And we had to start all over again to convince the new government to take on board this very sensitive project. Next slide. It's not working. Yes, that's the map of West Africa showing the Ebola outbreak and the density in the three West African countries. You have Sierra Leone there, Liberia, and then of course Guinea. As mentioned earlier, the epicenter in Sierra Leone kept changing from the eastern part of Sierra Leone where the original the outbreak spread from Kekedu. That was where the Ebola outbreak was first diagnosed, over into eastern Sierra Leone, and then spread right around Sierra Leone, as you can observe. Of course, that's Nigeria there. Yes, this slide shows the number of cases affected in individual country. As you can see, about 14,000 cases were diagnosed in Sierra Leone with about 4,000 deaths, which is quite in contrast to what happened in Lagos, where they had only about 20 cases. So the response was quite different. Initially, we had only one laboratory based in Kenema, and that laboratory was actually originally designed to diagnose Lassa fever, but was used to diagnose Ebola in the initial phases of the outbreak. But because of the number of cases, the capacity was outrun, and we then had to deploy over 15 mobile laboratories around the country in order to take care of the outbreak. In fact, the lack of laboratories actually prolonged or exacerbated the outbreak. Turnaround time were very high, and in fact, there were initially false positive and false negative results, and all of us know the consequences of that. Because of that, mobile laboratories were deployed, and the whole country was there. We had 16 international laboratories deployed as outlined there in the different parts of Sierra Leone, and these are the countries that deploy laboratories. This is actually where the biosecurity challenge came in. During the outbreak, over 100,000 samples were collected, and about 1/4 of them were actually Ebola positive. So at the end of the outbreak, we had a challenge because these samples were scattered in makeshift laboratories. At times we didn't even know where they were because most of these labs left, carrying some of the samples along, and we didn't know where the remaining samples were, and this posed considerable biosecurity challenge. So we did not know how many samples there were in the country, and we then had to think around it and find out what the solution could be. And then we thought that maybe having a biobank could be a very good solution to our problem. Incidentally, Professor Abayomi and I have known each other for the past maybe 20 years, 25 years. We trained together at Ibadan in hematology department at some point. I contacted him at that time. GET was just being formulated. He came over to Freetown, hung heads with our state operatives, the Minister of Health then, and the Chief Medical Officer, and we felt that the biobanking was a very good idea. So we actually started long before Lagos. So we thought around it and felt that we could look for donors. Canada government came, Canadian government responded to our call and provided funding initially to look for the samples, the location of the samples, and to quantify the samples. That was our initial project. That was the phase 1 of the project. The phase 2 of the project was actually to deploy these samples into temporary repositories before the biobank was designed. But between the phase 1 and phase 2 of the project, a lot of activities took place, which included SOPs were developed for the transportation and transfer of samples. We had to do that with our security agencies. Initially, when the concept of the biobanking was developed, people thought we were mad. Because of the devastating nature of the Ebola in Sierra Leone and the number of people who died, nobody wanted to hear a concept that entailed keeping Ebola samples in country. So we had to go all out of our way to explain to government that, well, this was a good idea and that it may well be these Ebola samples were a source of were a very good resource for research in future. We then brought on us the Office of National Security to identify the biobank site, and it was agreed that we locate the biobank in the military barracks. And so we went and met the head of the army, and he also thought we were crazy. And after a lot of briefing and counter briefing and meetings with his entire military high command, he finally agreed to give us a location where to construct the biobank. Professor Abayomi was all part of this process. He was back and forth Lagos, Freetown, for all of the activities. So we identified the biobank site, and the next phase was to construct the biobank. The design there you have, which was actually projected by the doctor from Lagos, that design was from Freetown. As I said, we actually started first. So whatever they did, they came after us. So I will just go, that's why I'm just going making a few points just to back up their presentation. So we went ahead and started training first all the staff that should be involved in the biobank. We trained the military officers, we trained the custom officers, we trained the medical personnel, we trained the laboratory side, we trained everybody with in as far as biobanking is concerned. In fact, before Professor Abami went with the concept of to Nigeria, himself and I took the IFBA exam. He got 93%, I think I got 92%. So we are both IFBA certified, not only in biorisk management, but also in biosecurity. But we cascaded the training to all major stakeholders. We also have a policy. We drafted the policy first in Sierra Leone before the one in Lagos was done. So whatever was done in Lagos, the idea was stolen from Freetown. Of course, Professor Christopher was very instrumental in training all our staff on LIMS and bioinformatics, and you also stole him from us. So I don't really have much to say. I think the presentation has been done by Lagos. The only thing is that they are far ahead. We were delayed because of a change of government. Our biobank is now in progress. But our own governance council has been already being formulated. We've been having meetings, and Professor Bahame, incidentally, is a member of our Sierra Leone Governance Council. That is in progress. We have also written a project proposal in collaboration with Professor Abawami, and we are sending it to WAHO for funding so that all the members of our Governance Council can be trained in accessing and how to actually release these samples when they are finally sent to the biobank. Thank you very much for listening.
Lagos, you are in trouble. You took everything from Sierra Leone, and you now perfected it. You made it. You are now, and no copyright, share? Intellectual property rights. Thank you so much for the two presentations. Since they are like a 2-in-1 presentation now, we will just take a few questions. Please let's not repeat questions. If you have questions, if you have a question for Sierra Leone that has been answered by Lagos, or you have one for Lagos that has been answered by Sierra Leone, please do not repeat those questions. So do we have questions? Do we need any form of clarity? Okay. Nobody is saying anything. People are tired. I know you want to go. Somebody just raised. Is this for Sierra Leone or for Lagos or for both? For Lagos. Joshua, please. No, they need to record for the media guys. The multimedia.
All right. Thank you very much, David Ishola, based in Sierra Leone. My question is for the Lagos team, really, because they are the ones that already have the biobank already active. This is with regard to access to the samples. Could you shed some light on what the policy is regarding how, who may have access to the samples, and what the process will be, and what kind of conditions associated with having access to the sample for the purpose of research and policy formulation. Thank you.
Thank you very much. Concerning number one, the biobanking section is ready. The other BSL-3 facility, we are still awaiting certification, and that is only the time we'll go into full operation. Concerning having access to whatever is stored in the bank, there is a governance council that you make a request to. Then there's an ethics committee that will look at your request and the purpose of the research. Then the issue of material transfer agreement will come in. Then whether it's going to be the issue of benefit sharing, all those ones are those that have been in the governance structure. So it's the governance council that decisions are made concerning what materials will be released and to who and how much and what the benefit sharing pattern is going to be. So it's not just that you can just walk into the facility and have access. Then we are going to look at your background, your references, your referees, your track record, so that because most of those pathogens are pathogens that you can use for their dual use, dual purpose pathogens. So for that, we are going to do a background check. So it's not just a straightforward approval. It's going to be streamlined in such a way that whenever you make the request, it goes through the governing council, goes to the ethical committee before it comes to the and then the decision we make at the governing council level, and then it will be released to you as at when you need it. Thank you very much.
Yes, Alan.
So the question is really to the two teams, and I'm trying to think that we've had now a few years experience in actually setting these up in two countries. And so I think the question really is there a process or a way in which the type of gains that has been achieved by both Sierra Leone and Lagos can actually be extended to the rest of the African continent, so that we actually take advantage of what has been achieved up till now? Because if not, we're going to just focus on two places, and I don't know what that answer is, but I'll be curious to hear from people from these two teams. How do they see or envision moving this across the entire continent?
Definitely. The ECOWAS Biobank project is already underway, and I'm a member of the ECOWAS Biobank project. Professor Abayomi is the lead of that project, and definitely whatever expertise that we have gained from this project will come in handy to the other countries if they so need it.
Thank you very much. I wanted to mention, in regard with your question, Alan, I wanted to mention that earlier, but I have the feeling I've spoken too much and too low, so I'll try to speak louder now. That a few months ago, here in Abuja, the West African Health Organization validated some regulations around transport of samples and also around material transfer agreements. And I think these documents are aimed to be used by the 15 ECOWAS countries. I was not there, so I do not have all the details of that, but I'm sure that the aim is to have these documents that should be used by all countries of the ECOWAS region.
So perhaps just in response to that, I think as we are thinking towards tomorrow afternoon when we reflect on where do we go from here, I think it might be important for us to think through statements around how do we then talk about the various regions, be it in east or west or south, so that we actually have a statement around what can we do collectively that will actually grow it further as a practical exercise.
Thank you so much, Team Lagos and Team Sierra Leone. We are moving. Please put your hands together for them. Team Lagos, see, we are celebrating you even without demanding for it. Okay, so we are moving into the second plenary session for today. We're going to have 3 presentations, and then we have the Get Book review. I will want us to leave here oops, it's dead. In another hour. Is that possible? Do you think we could work towards that? Okay. So that means the 3 presentations will be 10 minutes each. We'll take questions for another 15 minutes, making 45 minutes. And then the Get Book review and award presentation. How long is that going to take? Can we do that in 15 minutes? Okay. So 1 hour with the cooperation of everybody. I'm happy to be here until 9 p.m. It's okay. Exactly. But I think we have all earned it. We deserve it. We have worked for it. We were good yesterday. We made good progress. Today as well, we are trying. So in 1 hour, we want to leave here so that we don't also contribute to all this. Okay? Yes, you've been introduced. Thank you. Makes my life easy. Do you have your slides? Yes.
Good afternoon, everyone. You haven't started counting the minutes because my slides
No,
are
because
not.
I need to also get your slides.
So I'll take that time to introduce myself. Me to speak at this meeting. I work for the African Academy of Sciences. I don't know how many people here have heard about the Academy or have not heard about the Academy. I don't know which numbers are more, but very briefly, we are the Pan-African Academy of Sciences. The Secretariat is based in Nairobi, and we have 3 mandates. One is recognizing excellence, so we have the academy is an academy of fellows, so we have and work on the continent that has impacted the African continent. And then the number 2, we are a think tank for the African Union, and number 3, we define critical gaps and design programs and implement programs in the area of science, technology, and innovation. And that's why the title of my talk is Strengthening African Research and Development. So it doesn't have anything directly to do with biosecurity or climate change, but it is, we look at the entire pipeline at the Academy. That's from discovery all the way to impacting people on the bench. And so today I'm here actually because this gathering is bringing together a very unique group of people dealing with emerging and re-emerging infectious diseases. And the story I'm going to tell you today is a proposal for an initiative, and I would want us to be, I want you to, take ownership of this, because it's not for the academy, it's for the scientists, the African scientists, it's for the pharmaceutical companies, it's for all the people that have a stake when it comes to clinical trials. So the background to this story then is that there is a meeting or a group of funders referred to us as the HIROS group. I don't know how many people have heard about the HIROS group, but the HIROS group, HIROS stands for the Heads of International Research Organizations, and it's made up of the main funders, the NIH, Wellcome Trust, and all these big funders that fund research and development on the African continent. And they invited us, because we have a funding platform, to the HIROS meeting in Japan in 2010, and in 2016, sorry. And here we had a conversation on what are some of the challenges or what are some of the activities that we would want to do, and we are having hindrances one way or the other. And one thing that came out, which we've also heard from our scientists that we interact with, is the fact that they would love to see more activities and or funding or investment from the private sector into research and development. And so the heads of the HIROS then from the NIH and Wellcome Trust had conversations with a number of pharmaceutical representatives who then attended the World Economic Forum in Davos in 2017, and they agreed that this is something that they would be interested in. How can we, if we can identify the right pathways through which we can work as collaboratively to improve clinical trial work on the continent. And then Johnson & Johnson provided us with some seed funding, and we commissioned Dalberg consultants who then looked at or mapped for us what the current capabilities are. I'm sure maybe some of you here were contacted. Probably David was contacted. And we do have a report from that. Unfortunately, it's not open access yet, but we are writing the publication, and then we will put everything, will be open access on the AAS open access platform. So given, why then did we want to do the mapping first? We all know, we've had this in the morning, the African continent with a population of about 1.2 billion and growing exponentially, yet we only have 2% of the clinical trials happening on the continent, and you can see here in comparison to the other continents or sometimes even countries. And yet, even this 2% is not necessarily uniformly distributed across the continent. 50% of this work is happening either in Egypt or in South Africa. Yet we've had again in the couple of days we've been here that we are not homogeneous. We are very heterogeneous. Even within Nigeria itself, I'm sure there's enough heterogeneity to require clinical trials in different sites. So these are the methodologies that the firm that we commissioned used. They did a literature review desktop to see the research output from these institutions. They consulted with different PIs that are active in the space of clinical trials, and they administer surveys to different institutions. So they looked at anything from preclinical trials to phase 4. I was given only 10 minutes, so I'm going to rush through this. So here are some of the findings. This I don't think is surprising to anyone. We do have clinical research evident in Africa, but it's not always aligned to our disease burden. And this is a problem that we see even when we are working with our partners. Our partners sometimes have schemes that are not responding to our priorities, either as countries or as the African continent as a whole. If you look at our research in Africa by disease, you can see the big 3 are the most funded. Indeed, you know, understandably so, but we've heard again that non-communicable diseases are increasing. Respiratory infections cause a lot of deaths, but those are not necessarily the highest funded here. In terms of research in Africa by intervention, you can see that we have a lot of clinical trials in the area of drugs, but very low in vaccines. For the African continent, where we have emerging or re-emerging infectious diseases, you would think that we want more of this so that we can actually protect our communities. And then finally, in terms of the research by phases, you can see that we participate in phase 3 mostly, but not necessarily these early phases. So what's the problem here, and how can we improve on this and the phase 4 research? And then the finding number 2 is that clinical research activities are unevenly distributed, and advanced capacity is concentrated in 28 sites across 9 countries. So this is according to the data that they put together for us, and you can almost always predict where those the 9 countries. Of course, we've talked about South Africa and Egypt. Kenya comes up, Ghana. I'm not so sure about Nigeria if it comes up in this one. While this is what they came up with, I know that what the African Academy of Sciences would love to see is that, all these countries that don't have much happening also have some activity going on, so that we can build capacity across the continent, not just concentrated in specific areas. Clinical research capacity is concentrated in 28 sites. Again, this is just an emphasis of the previous slide, just pulling out some of the institutions that came up. And again, these are just examples. I know that, MRC Gambia, for example, is very good and should be up here. And these were the characteristics of these sites. They have continuous funding, they have training programs within their institutions, they have good collaborations and institutional governance. So these are all things that we talked about even when we had the panel conversation here. Unfortunately, the discovery aspect remains low on the African continent, so we can do research, but we don't push the findings down the innovation pipeline. Why is that? We need to talk about that, and we need to set aside funding so that we can push our own findings down the innovation pipeline. So these are some of the pressing constraints that came up, and again, these are issues that we talked about even in the panel: skills, infrastructure, networks, institutional governance, and funding. But for me, I guess it's always a question of, it's almost like a chicken and egg question for some of these. Do you need the skills and infrastructure to attract funding, or do you want the funding first so that you can build the infrastructure and skills? How do we go about that, and how do we solve that problem? Because this comes up over and over. But these 5 were key and visible in the sites that were excellent. So what are the next steps then? So these are the 3 recommendations that we were given by the Dahlberg report. So site validation, because they had no opportunity to visit these sites, but this hasn't happened because we believe that it will happen as we build this network of clinical trialists. And so this is what I'm talking about today, and I would like you to engage with me and the Academy in building an open access database for clinical trials capabilities and sites. So regulatory harmonization is one of the issues that stakeholders say, oh, we don't want to come to the continent because we don't really know how long it's going to take for our protocols to be reviewed and who is reviewing them, and it's different in Benin from what it is in Togo, so our multi-site clinical trials take forever. So how then do we work as a continent to harmonize some of these things so that even if it's at a regional level, we make it possible for collaborations to take place? So the African Academy of Sciences has some seed funding from the Gates Foundation to develop an open database for African clinical trials, capabilities, and sites. The objectives, this looks intense, but I will give a highlight of it. We want to increase visibility of these sites. We want these sites to have, to sustain their operations. This business of having a clinical trial for 5 years and then it closes down and then everybody has to find a job and then you start again. We want to bring that to an end so that by increasing visibility and increasing collaborations, we can have a continuous, hopefully a continuous activity in different sites. We want to reduce the unnecessary duplication of effort. Every sponsor has to come in and do a feasibility study, and that's their data, and they don't want to share it. We are talking to them and to see whether we can be able to actually have a basic questionnaire for different diseases that we can then share and reduce this and reduce on time and money. We want to have regulatory harmonization, as I've mentioned, and also this information will be used to inform funding to the sponsors and philanthropists so that we are not duplicating work or putting too much money in HIV and not in cardiovascular diseases, for example. So what have we done so far? We've had a meeting at the Grand Challenges in Berlin, where we had various stakeholders having a conversation and endorsing this project. But I'm here to hear from the scientists that work in clinical trials, what they think about this and what we need to put into this, what they would want to see on this platform. So we continue liaising with different stakeholders across the globe. We have had an RFI, request for information, and request for proposal. We now have a vendor that is going to develop for us this database. Continuous engagement with key stakeholders, that's why I'm here, again, to just talk to this community and hear what they have to say about this. At the center of this, we have a steering committee made up of African PIs, and we continue to talk to those that are not part of the committee, but we are also talking to all these other members or key stakeholders that would potentially be users of this platform. And going forward, we will continue with the stakeholder engagements. We have a big meeting happening in October. I think some of you have already been invited to that. And we will have to continuously update this database even after its launch, hopefully in Q2 of next year. And so how can you participate? I think Tunde has sent out this link. If not, you're going to receive it just now. Please go to this link and sign up so that you can receive information, so that you can be part of building of this clinical, open clinical trials database. Or you can send me an email to, this is my email address, or you can email the African Academy of Sciences communications team, and they should be able to give you any information that you might need. Thank you very much for listening, and I'm happy to take any questions either now or later. Thank you very much.
Okay, thank you so much. You take questions after the second presentation. Okay. Dr. Philip Onyebujo from the African Union joined us this afternoon. Please let's welcome him warmly, like we always do. So he has a presentation to make tomorrow. Sorry. I would like to invite Dr. Abiodun Deloye. Is he in the house or she? Dr. Abiodun is not here. Okay. So, Miss Niniola Williams, is she here? Niniola Williams is the Managing Director of DRASA, Dr. Ameyo Stella Adadevo Health Trust, an organization with a mission to keep Nigerians healthy and safe from public health threats. DRASA works with students, communities, health workers, and governments to improve hygiene and sanitation, reduce the spread of infectious diseases, and strengthen Nigeria's preparedness for future outbreaks. Prior to leading DRASA, Niniola worked with Management Sciences for Health, a global health organization operating in over 50 countries with a focus on priority health issues such as HIV and AIDS, tuberculosis, and malaria. Before MSH, Niniola worked with the brand agency while also serving on the core team of Keyo Soy, a Kenyan nonprofit focused on water, sanitation, and hygiene projects, as well as medical outreach programs. Niniola holds a BA in Cognitive Science, Neuroscience from the University of Pennsylvania, and a certificate in Social Sector Management from the Enterprise Development Center of Pan-Atlantic University. She is a most influential people of African descent, class of 2018 honoree, Avance Media 100 Most Influential Young Nigerians 2018 honoree, TEDx speaker, and an Acumen West Africa fellow. Please put your hands together for Niniola.
Thank you, everybody, and good afternoon. I'm going to crave your indulgence. I got the permission of the organizers to do something very small for all of us. I know it's afternoon and we're tired, so can we please stand to our feet and give ourselves some room? We're just going to do a quick stretching just to... Yes, it's okay. Okay. Quick stretching, quick stretching. Yes. All right. Thank you very much. Yeah. You can stop now. Thank you. Okay, so I'm here to speak about a different angle of things. I know we've been talking about a lot of complex issues, climate change, disease transmission, things that are very complex. And my presentation is going to bring the human behavior aspects of these things, because we know that humans drive all of these things we've been speaking about. And I'm going to speak specifically as it relates to antimicrobial resistance. So this is Fatia. She is one of our youth ambassadors, and I'll explain what that means. She's 17 years old, and she lives in a very densely populated slum in Lagos. She's one of 5 children. Her mother died of an illness, and so she lives with her father and her stepmother, who are both traders. So we met Fatia in September 2017 when we started a health and hygiene club in her school. So the same way the students have access to join the Red Cross Society or to join Girl Guides or to join the literary and debate club, we started a health and hygiene club, and Fatia was one of our founding members. So I'll talk a little bit about the program. Why did we decide to focus on youth and engage them? JASA was founded in order to look at how do we support government and the health sector? How do we work at the facility level, training health workers on infection prevention and control? However, we realized that if we only focus on the health sector, we're missing the boats, which is the people in the communities where we were going to. And when we got to the schools, we realized that there's a huge population of youth. In Nigeria, some statistics will say that 50% of our population is under the age of 18. So we have a lot of youth all over the country, and they have energy, they're ready to learn, and they want to be given responsibility to do something significant. So we decided to tap into this to create a program. We piloted the program in 4 schools in Lagos State from 2017 to 2018, and that pilot program gained the attention of WHO. WHO Nigeria office, as well as WHO Afro and WHO HQ, and with their support we got funding from Global Affairs Canada to scale the program. So altogether, we've trained 460 youth over the course of 2 years through the program. And the reason we decided to focus on antibiotics and antimicrobial resistance is we realized that self-medication was a huge problem. We would go to the schools and talk to them about their health-seeking behavior. What do you do when you're not feeling well? And they would immediately tell us, oh, they take the red and yellow capsule, or they go and buy something from the chemist down the road. And we realized that that behavior was driving what we were seeing in terms of the data of resistance. So in addition to antimicrobial resistance, we also deal with other issues like hand and personal hygiene for the girls, menstrual hygiene, sexual health, food safety, and environmental sanitation. But I won't focus on those for this presentation. So AMR, what is it and why did we decide to focus on it? Obviously, as you can see on the left, antibiotic use is one of the biggest drivers of resistance. And on the right, I have some statistics from Nigeria, which we don't have a lot of data, but there were some studies done in Edo State and Rivers State that showed that under the age of 5, hospitalized children were between 76 and 100% resistant to 3 different types of antibiotics. And we know that schools are big points of exposure for infection, so that's another reason why we're doing this program. And in addition to this, in June of this year, just 2 months ago, a study was done that showed that in Abuja here, youth believe that using antibiotics is equivalent to contraceptives. So after having unprotected sex, they take antibiotics. The boys encourage the girls to take antibiotics to prevent pregnancy. I'll skip over this because of time. So just to demonstrate the magnitude of the problem, only 8 of the 51 drugs that we currently have in the pipeline to treat AMR pathogens are actually innovative. Most of them are just modifications of existing classes of antibiotics that we have. And to give tuberculosis as a specific example, only 2 new drugs have been added for TB in the last 70 years. So AMR and climate change, how are the two things related? Well, we can start by saying that both of these things, people have been shouting about these problems for decades, but it's like we've only just about woken up recently. You can see this quote here from 1988. This microbiologist said that if there was a competition between bacteria and humans, there's no guarantee that we would survive. That rings true still till today. And we know that climate change, as long ago as the 1970s, people were talking about the effects of climate change, but it's only recently become a hot topic. And now we know that climate change is indeed contributing to the rise of resistant organisms. We heard from Dr. Tafa earlier today that climate change affects disease-carrying vectors like mosquitoes and ticks. We also know that climate change increases the incidence of food and waterborne related pathogens. So there's clearly many studies, which I have them here, but I won't go into them, that show the impacts of climate change on resistance. Last year, a study was done in the US that showed that temperature increases and population density, 2 problems that we have here in Nigeria, are increasing antibiotic resistance. And specifically, just a simple 10-degree change in temperature caused increases of antibiotic resistance of 3 different pathogens: E. coli by 4.2%, Klebsiella by 2.2%, and Staph aureus by 2.7%. So the bottom line is that we know that climate change has a factor on AMR. And it's been predicted that by 2050, if nothing is done, there are going to be 10 million deaths every year and $100 trillion spent on fighting AMR. But those estimates are in exclusion of the climate change issue, which again buttresses the reason why we need a multidisciplinary approach to dealing with some of these problems. So back to our program. What did we do? We developed and trained youth champions who were called ambassadors. And what they do is they go into their communities and drive good health, hygiene, and antibiotic practices. So we educate them to go and do the work in the communities. Our ambassadors are 59% female, 41% male. We have about 32 ambassadors per school. The mean age is 15. What did we find? So from this last year, we found that at the end of our program, there was an increase in the number of ambassadors who understood what antibiotics were, because there's a lot of misconception. Like I said, they think antibiotics are contraceptives, they think they work for malaria, they think they work for viruses, and there's also been an increase in the knowledge that they have about how to use antibiotics. We found that they were not using them properly. They were not finishing the entire dose. They were sharing antibiotics amongst themselves. So these were all things that we were able to address through the program. Hand washing, a very cheap, simple, and effective method to stop the transmission of disease, but many of them didn't understand why they need to use soap. They thought just rinsing their hands with water was enough. So that's another misconception we were able to correct. Most of them, like I mentioned, practice self-medication. When they don't feel well, they decide what they want to do and they do it. We saw an increase in the knowledge of needing to be tested before taking malaria drugs. I'm sure many of us here in Nigeria know that when people have a fever, they usually think it's either malaria or typhoid. Those are usually the diagnoses that happen. We never think about other causes of fever. There was also a slight increase in those that understood the need to get tested when they have a fever. This picture shows one of the activities we had them do was create a super germ. So draw a character that was resistant, explain how it became resistant, what it can do, and what can be done to prevent it from spreading. This is one of the testimonials that we have. After asking this ambassador, what was your aha moment? The answer was, the time you taught us antibiotics. I didn't know antibiotics are for bacteria, because if I'm sick, normally we just do self-medication. My mommy gives us drugs. We go to the chemist and buy drugs. But as you taught us more about antibiotics, I know that it's not for all diseases or sicknesses. That if we're using it for the wrong disease, we are actually harming ourselves. So what now? The takeaway from me from this conference, alongside the work that we do, is that we need to not forget the human behavior aspect of these challenges that we're trying to fight against. It's very clear that behavior change is hard, but if you do it in the right ways, where you bring people in, engage them, and empower them, it can be done successfully. And it can help take the pressure off just government. Everyone's waiting for governments or the scientists or the experts to come up with the solutions without thinking about the importance of engaging the people in the communities, or in this case, the youth, who can really drive change from the bottom up. Thank you.
Thank you so much for that human angle brought into this, the behavioral angle brought into this, attitudes, knowledge, capacity enhancement brought into this conversation. Before we take your questions, I'm sure you have questions for the two presenters. Do we have questions? Okay, 1, 2, 3. Okay, on this side of the room. 4. Okay. 5. All right. Oh, okay, let's take the questions. Let's start from to your right, yes. To your right, your right. Where's your right? Yes.
Thank you. So actually I have two questions, one for each presenter. For the first one, Jennifer, it's about the database or the platform. Because there is already a Pan-African clinical trial registry which has been launched by EDCTP and which is also recognized by WHO. So my question was, what would be the added value, or what would be the difference, or why not building on this already existing database? And for the second presenter, maybe it's just a simple question or stupid question, but in Europe, we cannot buy antibiotics at the pharmacy without having a prescription from the physician. Why couldn't we at least start from there? Thank you.
Very nice presentations. I think my first question follows on to Jennifer from the PACTA. The Pan-African Clinical Trials Registry is run from my unit, and I'm sure Jennifer has been in touch with the managers who are involved there. But I'm worried that you didn't put us as stakeholders. I know you put PACTA, which we are involved in, but it's different from PACTA, which is a trial registry. And for the second presentation, for the work, the very excellent work, I was just wondering how we could integrate other activities into that, like vaccination, to encouraging vaccination uptake in addition to the antibiotic resistance.
Thank you very much, ladies, for those two bright presentations. My question goes to Jennifer about the clinical trials and vaccine trials. I'm wondering if you, in your studies that are very helpful, I think, if you consider the use of health demographic surveillance systems, and if you have the feeling that this had a value in implementing vaccine trials in Africa, in our countries where often we do not have a census or very regular census. I think it's very helpful to have HDSS, and we have a few ones in Burkina Faso, in Nanoro, in Nuna, in Kenya. I know that there are two in Mwanza, and one in Kilifi, and probably others. And if this matches the places where you've seen that most of the trials were realized.
Yeah. So my question is to Ms. Williams, and I think I want to congratulate you on some excellent work. I think it's always challenging working with youth. I think that your data actually shows just the value which you bring to it. And I know that you show data for how the youth has actually gained knowledge. Are you perhaps thinking about following these up to see how they then become true ambassadors in teaching more kids or more youth as a way of actually having a more comprehensive assessment as to how well they are doing as ambassadors for your project?
Thank you very much. My question is to Jennifer. Actually, somebody has already asked a question about Pan-African clinical trial registry, so I want to see the difference between your own registry and that of Pan-African clinical trial registry, which is open access and has been used for some time now. Thank you.
Okay, thank you for the questions. The first question, you are exactly correct. If we had regulation in the pharmaceutical sector regarding the way antibiotics are distributed, it would cut down a lot on this issue of resistance. Right now, I could go to the market and buy a carton full of antibiotics if I wanted to, and nobody's going to stop me. So there has been a lot of advocacy for policy change and enforcement of the policy, because it's one thing to have a policy, it's another thing to actually enforce it. The informal drug sector in Nigeria is huge, so part of the concern is if you put restrictions on these supposed businessmen and women, what do they then do if you shut them down? So there's a lot of complications around the regulation of these particular class of drugs. But on the flip side, there are also issues even within those that prescribe. So antibiotic stewardship programs don't really exist in most of our health facilities. So doctors often overprescribe or prescribe without lab results, which again furthers the resistance problem. So it's something that we're aware of, but I think advocacy and with time we'll get there. The second question on other topics that could be added to the program, definitely when we started, we focused more on personal hygiene and environmental sanitation, and over time other topics were now added. Vaccination is a great one, and it could also be added in the future. Our goal with this program is to build a foundation and a platform that other things can be plugged into, and I think that's a great suggestion, so thank you for that. The last question about how are we actually measuring their effectiveness as ambassadors? Because of time, I didn't go into the details of the program, but our M&E for that is around the fact that every ambassador has to conduct a school-wide assembly during which they address the rest of the members of the school and sort of step down what we're teaching them in the clubs. In addition to that, at the beginning of every weekly meeting for the clubs, they are required to report on what they've done as ambassadors in the previous week, whether it's, we've heard things like, in my church, they gave me 10 minutes to teach them how to wash their hands properly, or I taught my younger brother how to do, just things like that. So those are all anecdotal examples of them demonstrating their ability to actually be ambassadors. Thank you.
Yeah, so thank you for the questions. I think the first question, which I kind of anticipated, is the one on PACTA and other websites that have similar data. But what we are building is not a registry. And our platform is going to have links or APIs. IT people here can explain what that means, but basically we will be able to pull the data or link to the PACTA data, link to the clinicaltrials.gov data, link to the European clinical trials website also. The addition that our platform will provide is the regulatory framework information, and information on review boards, ethical review board, institutional review board. So we'll have all this information on our platform. We are working closely with AVREF. AVREF says they have this information, but it's not in any form that can be easily accessible. So we are building a tool so that we can have this tool online. And we are also linking with, as I mentioned, ethical review boards and institutions that are dealing with that so that we can have all that information on our platform. So that will be the addition. Is that okay? And I'll add you to the slide. And then on the question on demographics, so our initial goal was we would link to the Institute of Health and Metrics and Evaluation, the University of Washington IHME, which has this data and epidemiological data, and overlay it with where the clinical trial sites are, so that you can just log in and see, in this region we have this particular epidemiology for disease X, and there's a site or no site. Because the other thing that the other objective of this initiative is to actually highlight the gaps that we have in the different sites, because the pharmaceutical companies actually say, if we know what the issues are, and if we need to collaborate with the site, we'll go there and fill the gap. So they're willing to actually come and help people build the areas that are lacking, or the infrastructure that is lacking, or the skill that is lacking, so that they can conduct their clinical trials. As long as it saves them time and money, they will come. So that's how we intend to look at it. But I do like your suggestion too. So I'll have a conversation with my other colleagues about it. I think that's it, because his question was related to her question. Yeah. Thank you.
Okay. Are we fine? We've learned a lot today. We've given a lot. And it's been a long day. But before we close for the day, I would like to invite the GET team to present the book. It's just called the book for now, until they unveil it. So are you making the presentation? Are you? Please don't forget to stick your stick-on sheet onto the wall. And if you look around the room, I'm sure you'll find your flag. The flag of the country you represent, where you live, not where you're from your address. So please look around. If you can't find your flag, let us know. So who's from France? They've left? Who's from Germany? Who's from Ghana? How about Ghana? Mali. Hey. Australia. Australia? Where else? South Africa. Hey. Nigeria. Lagos. Where's the flag of Lagos? We can't find your flag. We tried to buy a flag for Lagos. We couldn't find it.
Yeah, good evening, ladies and gentlemen. We are actually saving the best for the last. And I promise it won't take more than 10-15 minutes. We are going to do two things together. The first one, or the most important one, is that we are going to be giving some awards this evening. GET has been around for 5 years. GET started 5 years ago as a direct response to the Ebola crisis we had in West Africa. And it was almost like a spontaneous consortium that started because the issue was huge, people were dying, and there was a need to start something. And that was how GET was started. But over the years, we've grown to become one of the biggest biosecurity and One Health-based organization on the continent. And as you know, organizations don't just grow. It's human beings that are growing them. And we have some people over the years that have contributed to the growth of this organization. Some people contributed to fighting the Ebola crisis on the continent. And in the process, some people lost their lives. So would they make fit that after 5 years, it's time for us to say thank you to some people? To those that survived, and to those that did not make it. So this evening, we are going to be calling out some people to say thank you to what you did and what you are doing for the continent. To say thank you for what you did during the Ebola crisis, and to say thank you for what you are doing in the health sector in the continent. And the second thing we are going to briefly talk about is a book launch. Not a book launch, but we're going to talk about a book that has just been published, written by GET, experts from GET. The title of the book is Socio-Cultural Dimensions of Emerging Infectious Diseases in Africa. After the Ebola crisis, GET had so much experience. And you see, if you don't put this experience to writing in publications and in books, it can just go with you. So instead of allowing such experience to waste, GET has been able to publish a lot of journal papers. At least we have 7 journal papers that we've published. And this is a book that was produced by Springer that just came out last month. The person that was supposed to give the book presentation is not around, but Professor Abayomi is one of the editors, so I know he'll be able to say one or two things on the book. But before we go to that, I'm going to call out some names of people that we're going to be giving awards to this evening, and we're going to say thank you for what you've done. Please, when I call your name, just come up and sit on the chair on the podium here. The first person is Dr. Jide Idris. Dr. Jide Idris is a former or the outgoing commissioner for health in Lagos State, and he was the chief general when the Ebola crisis happened in Lagos then. He was the brain behind containing the Ebola crisis in Nigeria, and he is one of the founding members of GET. So for your contribution to GET, for your contribution to the health sector in Nigeria, in West Africa, and on the continent, we are saying thank you, sir. The second person I'll be calling to the podium is Professor Sir Geval. Professor Sir Geval is the head, or was the head of the team that fought Ebola in Sierra Leone. He was the coordinator of the team that coordinated the Ebola response challenge in Sierra Leone during the Ebola crisis. And he's also the head of the GET team in Sierra Leone. Thank you, sir, for your contribution to the region. The next person I'll be calling is, the next person I'll be mentioning is Dr. Ameyu Adadeva. Dr. Adadeva was the person that was the doctor that attended to the first Ebola patient that entered Nigeria via Sierra Leone, I think. And she was the one that raised the alarm that there may be a possible case of Ebola in the country then. But unfortunately, she was infected with the virus and she could not make it. We lost her to the Ebola crisis. So before we go on, can we just have a minute stand up in respect of Dr. Ameyo Adadevo? May her soul continue to rest in perfect peace. And with us there is Mrs. Nini Ola that will be collecting the award on her behalf. Dr. Adadevo may not be here with us, but our work continues. And it continues in people like this that are going around the world doing the good things that she left. Mrs. Nini Ola is a CEO or DG of DRASA. That's the NGO that was set up in the name of Dr. Adadevo. The remaining two awardees are not here with us. One is Dr. Moyo Obada. He is the present Minister for Health in Zimbabwe. You agree with me that we are having crisis in Zimbabwe now in the area of, what is it called? Food issues, drought, and things like that. And because of those challenges, Dr. Moyo Obada will not be here with us. But I think Professor Abayomi will collect the award on his behalf. The last person is Professor Godfrey Tangwa. Professor Godfrey Tangwa is a leading bioethics on the continent, and he was actively involved during the Ebola outbreak in bioethics issues, making sure that we did not cross the boundary as a result of the urge to solve the challenges we had during the Ebola crisis. So we needed a lot of bioethics, a lot of ethical issues when it comes to medical challenges, especially during an outbreak. Different people will start trying different things. And Professor Godfrey Tangwa was the head of the ethic group then, saying these are the boundaries you cannot cross, these are the limits, setting ethical standard during the Ebola crisis. And he's also one of the founding fathers or founding members of GET. But he's not here with us, and I think he's a Cameroonian. So I'll call on Professor Charles Wisunge to collect the award on his behalf. Yes. Alan, please can you come up? Can you come up and give the awards? Can you come and present the awards? Dr. Jide.
I'm not receiving an award.
He will be giving out the awards, Dr. Jide. May I call on Dr. Jide to collect his award, please? You want to say anything? Thank you, sir. The next award goes to Professor Sir Gevau. The next award goes to Dr. Ameyo Adadevo. Okay. Dr. Moyo Obada. And lastly, Professor Godfrey Tangwa. Yeah. So I also want to use this opportunity to say a big thank you for those that have been with GET for 5 years. 5 years is not a small feat for an organization like GET. And we've been trying to organize the annual conference. This is the 5th annual conference on EID and biosecurity. It's not easy doing it year in, year out. To the Lagos State team, thank you very much. To people like Maker that are coming year in, year out, to Alan and others that have been with us for 5 years, and make sure that we have been able to continue this conference on a yearly basis. I want to assure you that next year will be better, will be bigger, and will be greater than this. Thank you very much, and have a wonderful evening. Please. Thank you. Thank you. Did you say anything about the book? Or should we just round up and go? Okay. Should we round up and go? Yeah. So, we've come to the end of today's program. Tomorrow we'll be starting by 9 a.m. Thank you for staying from 8 a.m. to 6 p.m. Have a wonderful evening. Enjoy yourself in Abuja. And